Surgical Pathology from Makhan Saha, page number 855. Okay, and let's say whether we can finish it to 860. But in the end, I will say, I will, sorry, I will, I will speak up the page we have completed. So we have started from page 855, and that is surgical pathology. Benign gastric ulcer, lesser curvature, ulcer in the region of lesser curvature, pyloric canal, mucosal fold converging towards the ulcer, ulcer margin, greater curvature, side cut open. This is a specimen of a stomach cut open along the greater curvature and showing an ulcer in the region of lesser curvature. The margin of the ulcer are well defined. There is convergence of mucosal folds towards the margin of ulcer. So this is specimen of benign gastric ulcer. Why do you say this is a benign ulcer? Ulcers along lesser curvature are more common benign, and the margin of the ulcer are clear cut and not everted, surrounding gastric mucosal folds and are converging towards the base of the ulcer. In malignant ulcer, these folds are effaced around the ulcer. What are on the sites where peptic ulcers may occur? Peptic ulcers occur due to acid peptic digestion and may occur in sites exposed to acid and pepsin stomach. Majority occur near the lesser curvature duodenum. Most common in the first part, insulinger license syndrome, as it may affect second and third part. Lower end of esophagus due to reflux esophagitis, Michel's diverticulum, due to presence of heterotropic gastric mucosa, stoma of gastrointestinal towards the jejunum. Which factors are responsible for development of chronic gastric ulcer? A number of factors are responsible for development of gastric ulcer. Diminished mucosal resistance due to some nutritional deficiencies predisposes the mucosa to acid peptic digestion and formation of ulcer. Non-steroidal anti-inflammatory drugs and smoking are important etiological factors for development of peptic ulceration. Antilostasis results in hyperchlorhydria due to increased gastric release and is one of the factors for development of peptic ulceration. Bile reflux. Reflux of bile through the pylorus results in bile reflux gastritis, which predisposes to formation of gastric ulcer. Helicobacter pylori injection, one of the important etiological factors for development of the peptic ulcers. How does Helicobacter pylori cause peptic ulcer? Helicobacter pylori may colonize the gastric epithelium. Helicobacter pylori releases some cytotoxins which induce gastritis and subsequent breakdown of surface epithelium resulting in ulceration. Helicobacter pylori also incites an inflammatory reaction resulting in accumulation of acute and chronic inflammatory cells in gastric epithelium. Helicobacter pylori hydrolyzes urea and liberates ammonia, which is a strong alkali. This causes increased secretion of gastrin, which leads to hyperchlorhydria. This is one of the predisposing factors for development of duodenal ulcer. Does Helicobacter pylori normally colonizes duodenum? Normally, Helicobacter pylori does not colonize duodenum. Helicobacter pylori colonizes stomach, causes hyperacidity due to hypersecretion of gastric juice. Due to excessive gastrin release, the excess acid an acid in the duodenum causes gastric metaplasia of duodenal epithelium. Helicobacter pylori can colonize gastric metaplasia duodenal epithelium and causes series of changes resulting in duodenal ulceration. Which part of the stomach affected by chronic peptic ulcer? About 95% of peptic ulcers in the stomach are situated under lesser curvature in the pyloric region, 5 centimeters from the pylorus. The greater curvature fenders in the cardia are rarely affected. What are histopathological characteristics of benign peptic ulcer? The destruction of epithelial lining. At the margins, there is proliferation and downgrowth of epithelial lining. There is variable destruction of muscular cut. The base of ulcer is covered with granulation tissue. There is infiltration of both neutrophils and chronic inflammatory cells. The arteries, so endarteritis obliterans changes. There is a zone of fibrous tissue at the base of the ulcer. The termination of nerves. The termination of the nerves may be seen in fibrous tissue. Why benign ulcers are more common in lesser curvature? The lesser curvature and adjacent part of the stomach constitute the principal food route or mesenteric, along with passes the bulk of food entering the stomach. This area is subject to wear and tear, which explains increase and incidence of ulcer in this site. What is the risk of malignant change in chronic peptic ulcer? Chronic duodenal ulcer never turns malignant, although extremely rare. Chronic gastric ulcer may turn malignant. Histologically, the appearance will take the appearance will like a benign gastric ulcer with focal areas of malignant transformation. The incidence of such malignant change has been quoted as 0.1%. What is ulcer cancer? The patient is identified as having an ulcer in the stomach either endoscopically or radiologically, which on biopsy reveals malignancy. What do you mean by basal acid output BAO and how BAO is estimated? BAO is defined as amount of acid secreted by the stomach in 1 hour under basal condition without any stimulation. Patient is kept fasting overnight for 12 hours by Royal stew is inserted in the morning and 12 hours nitric acid is aspirated and discarded. The next gastric acid is collected and aspirated Royal tube every 15 minutes for 1 hour, and total acid in this 1 hour juice is estimated. This BAO, normal BAO, is 5 millimole per liter. What is peak acid amount? Sorry. What is peak acid output PAO and how will you estimate it? This is the amount of acid secreted by the stomach over 1 hour after maximal stimulation. Patient is kept fasting overnight while still inserted at 8 a.m. Gastric juice aspirated and the overnight secretion is discarded. Gastric juice is then collected every 15 minutes for 1 hour to estimate BAO. Injection pentagastrin 6 mg by per kg. Our body weight is injected and gastric juice is collected for every 15 minutes for next 1 hour. The mean acid secretion into higher adequate is calculated and amount of acid secreted in 1 hour is calculated, which gives PAO normal PO is about 27 millimole per liter. What do you mean by achlorhydria? It can be defined as when a stomach cannot produce a juice with pH less than 7, even after maximum stimulation. Achlorhydria is found in 40% of patients with carcinoma stomach. What happens in Jollinger-Ellison syndrome? JS with regard to secretory studies, achlorhydria, lack of acid and digestive juice in the stomach. In JS, there is hypergastrinemia and parietal cells are maximally stimulated under basal conditions. The POA on further stimulation, injecting pentagastrine. There is no further rise of acid over the BAO level. What is the role of insulin test? Insulin test was done earlier to access completeness of vagotomy. Why insulin test is not done nowadays? Insulin may cause fetal hypoglycemia, so insulin test is placed by chew and spit test. What is chew and spit test? In a Rile's tube is passed to an empty stomach and overnight juice is aspirated and discarded. Gastric juice collected over next 1 hour. To calculate BO, patient takes the food in the mouth, chew it, and instead of swallowing, spit it off. Gastric juice is collected for next 2 hours every 15 minutes. And mean acid level in each hour is calculated. Early responses. The test is positive in first hour. Delayed response if the test is positive in second hour. When do you call the test is positive? If basal sample wasn't tested and a rise of 10 millimole per liter is taken as positive, and a basal sample contains some acid, a rise of 20 millimole per liter is taken as positive. If the response is positive, what does it mean? An early positive response suggests incomplete vagotomy may be corrected by completion of vagotomy. Delayed positive response is usually due to antral gastrine release and may be corrected by enterectomy. How does patients with chronic gastric ulcer ulcer present? Why biopsy is required before initiating treatment of gastric ulcers? Multiple biopsies, about 10, are required to exclude the malignancy. Modern anti-secretory drugs may show healing event of a malignant ulcer, but does not cure the malignancy. Hence, biopsy may be required even if the ulcer has healed if the symptoms persist. Perforated benign gastric ulcer, perforated gastric ulcer converging mucosal folds. This is a specimen of a stomach cut open along the greater curvature, showing ulcer near the lesser curvature. The ulcer has penetrated the full thickness of a stomach, and there are converging mucosal folds towards the base of the ulcer. So, this is a case of perforated benign gastric ulcer. What are complications of peptic ulcer? Acute complication, perforation and hemorrhage. Subacute complication, residual abscess. Chronic complication, stenosis pyloric stenosis, hourglass stomach, penetration into pancreas or liver. Malignant changes rarely occurs in chronic gastric ulcer, but not in chronic duodenal ulcer. What are the pathological changes following perforation of chronic peptic ulcer? There are three changes in development of peptic, sorry, peritonitis following peptic perforation, a stage of chemical peritonitis, a stage of peritoneal reaction, or a stage of elution, a stage of bacterial peritonitis, or a stage of abdominal distension. Carcinoma of stomach figure. Carcinoma of stomach figure 18.3 to see. Let's say curvature of the stomach, anterior wall of the stomach cut open, greater curvature of the stomach, proliferative growth. This is a specimen of distal part of the stomach. One wall is cut open, showing proliferative growth. In the pyloric region, the serosal side should be seen to look for any extension of growth toward the serosal surface of the stomach. So this is a specimen of proliferative type of carcinoma of the stomach involving the pyloric region of the stomach. This is a specimen of a stomach cut open along the greater curvature and showing an ulceration and ulcer. An ulcerative lesion at the body of the stomach along the lesser curvature. The margin of ulcer is is rolled out and everted. There is a flattening of mucosal folds around the ulcer. So this is a specimen of ulcerative type of carcinoma of the stomach involving the body of the stomach. Surgical pathology. This is going to be page number 861. Gross thickening of the wall of the stomach, lesser curvature, greater curvature, smooth mucosa of the stomach. This is a specimen of the stomach from which part of the anterior wall of the stomach is cut off. There is the thickening of the whole stomach. The capacity of the stomach is reduced to a great extent. The whole of the mucosal aspect appears smooth due to flattening of mucosal fold. This appearance is suggestive of generalized rhinitis plastica of the stomach. Smooth mucosa, pyloric region, organ mucosa, gross thickening of the wall of pyloric region of the stomach. This is a specimen of slice of the distal part of the stomach showing thickening of the wall of the stomach. There are wide strands traversing the wall of the stomach. The mucosal aspect of pyloric region appears smooth. The normal mucous membrane is seen more proximally. The appearance is suggestive of localized type of rhinitis plastica involving the pyloric region of the stomach. What are the important etiological factors of carcinoma of the stomach? There are various factors causing gastric cancers. Important factors are dietary factors, gastritis due to ingestion of spillage as a predisposing factor. Excessive salt intake and smoked food causing excessive amount of nitrates are important. Etiological factors for development of carcinoma of the stomach. Nitrates are converted into nitrates and nitrosamines, which are potent carcinogens. Diet high in raw vegetables, vitamin C, and antioxidants may be protective. Helicobacter pylori infection. Helicobacter pylori causes gastritis, gastric atrophy, and intestinal metaplasia. These predisposes to development of carcinoma of the stomach. This mainly involves the body of distal stomach rather than proximal part following peptic ulcer surgery. patients who are gastrectomy. Gastrointestinal pyroplasty has increased risk of developing gastric cancer by reflux gastric and gastritis following peptic ulcer. Surgery has been incriminated as the important factor. Pernicious anemia and atopic gastritis are important predisposing factors. Cigarette smoking and alcohol are important factors. Gastric polyps are also really precursor of gastric cancer, also cancer. Rarely benign gastric ulcer may undergo malignant changes. The incidence is 0.1%. Genetic factors. Mutation of HRA is also known as transforming protein P21 oncogenes and overexpression of CERB beta gene are incriminated in genesis of gastric cancer. The aromatase polyposis coli gene responsible for familial polyposis coli has also been incriminated in about 25% patients of cancer in the stomach. P53 is rumored to suppress a gene, but its role in gastric cancer is not clear. Abnormalities in P53 tumor suppressor gene has been found in patients with intestinal metaplasia and in patients with advanced gastric cancer, hereditary non-polyposis colorectal cancer, SNPCC, is associated with genetic abnormality which involves deficiency of a mismatch repair genes. There is increased incidence of gastric cancers in families of these patients. 21%, 22%, 23%, 24%. What is the relative size distribution of carcinoma in stomach? Pyloric regions 47%, body 23%, cardia 21%, fundus 2%, plastica 7%. What is Lawrence classification for gastric cancer? Two main types are described. Distribution of carcinoma in stomach. Type 1 intestinal type of gastric carcinoma arises inside of intestinal metaplasia forms polypoid tumor or ulcer. Type 2 diffuse gastric cancer infiltrates deeply in the stomach wall without producing obvious mass lesions. So what are microscopic types of carcinoma in the stomach? There are four principal varieties of gastric cancer. Proliferative type. This is a bulky cauliflower type of growth proliferating into lumina of the stomach. Ulcerative type. This is most common type carcinoma of the stomach. It arises most common in pyloric antrum. Raising towards lesser curvature side and ulcer has rolled out inverted edges with surrounding induration. The colloid or mucoid type. This is a rare variety and appear as a massive tumor of gelatinous appearance. Histologically, the cancer cells line the accumulation of colloid. The cells line the tubular gland may also get distended with mucinous material. Lanatis plastica. This is also a rare variety of tumor. The tumor cells infiltrate the submucosa and submucosa and muscle coat extending without protruding into the lumina of the stomach. There is proliferation of fibrous tissue in the submucosa giving mother upper appearance. This may either be generalized or localized. In generalized variety, the whole stomach contracted and rigid. Mucosa may appear normal or there may be small superficial ulceration. In localized variety, it usually involves the pyloric region of the stomach. And what do we mean by early gastric cancer? Gastric cancer confined to mucosa and submucous irrespective of lymph node status. Any N is considered as early gastric cancer. However, when lymph nodes are involved with T1, it is then designated as early stimulating advanced gastric cancer, as prognosis is worse once the lymph nodes are involved. Type 1, type 2, type 3B, type 2B, type 3C, type 2C, and type 3. What is Japanese classification for early gastric cancer? Type 1, protrude, type 2, superficial like elevated, fat, and depressed. Type 3, excavated. What is Borman's classification of advanced gastric cancer? Advanced gastric cancer extends beyond the submucous coat and involves the muscularis propria. Depending on the extent of involvement, advanced cancer is classified as type 1 to type 4.